Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Australia's privacy regulator has recently updated its guidance to clinicians about contacting their patients' relatives about their genetic risk of disease. The MJA is featuring an article on the subject by Dr. Jane Tiller as an online first this week ahead of its publication in the journal in August. Dr. Tiller is a lawyer, genetic counsellor and public health researcher. She's the ethical, legal and social advisor in Public Health Genomics at Monash University. So Jane, I'll just start off with a broad question. Tell us about the latest guidance from Australia's privacy regulator on contacting a patient's relatives about their genetic risk.
This is an issue that we've been working on for a number of years. And the issue at the heart of this is what happens when someone has a genetic result. It's showing that there's an increased risk of disease. Of course, because it's genetic, that means that their family members might also have inherited that same disease risk. But maybe they don't they're not in contact with their family. Maybe it's difficult to contact their family members for whatever reason. And the doctor says, what if I just write directly to your family members? The patient can give me your details and I can write to them to let them know that there's a test available to them that they can find out. But there's been a big question in Australia and internationally about, is that a breach of the relative's privacy? And so they haven't asked to get that information. They haven't been asked to send the letter and they haven't asked to have their contact details used to contact them to tell them about this genetic risk. And the question has been, what's the status under privacy law of using the relative's contact details in that way to let them know about their genetic risk? And there are guidelines in Australia that deal with what you can do even if your patient doesn't consent. So if your patient says, I don't want to tell my family members about their genetic risk, I hate my sister, I hope she dies of cancer, there's actually ways under the guidelines under the Privacy Act that you can take steps to let that family member know even without your patient's consent. And it seemed obvious that if your patient therefore consents, that you can still do that as well. But it seems like there's been a little black hole of clarification where that wasn't made clear in those guidelines. And clinicians were really concerned that even if their patient consented and provided the contact details, that they wouldn't be able to contact the relatives. And so the recent guidance that's come out from the Privacy Commissioner, the Office of the Australian Information Commissioner, which is Australia's privacy regulator, has said that under the current Privacy Act, it isn't a breach of privacy in those circumstances to use the contact details given by the patient to contact their relatives to let them know about this kind of genetic risk.
Okay, so how would that work? I'm at my GP, I've been diagnosed with ovarian cancer, and I have a sister and a daughter who could carry that gene. What happens then?
So the way it would work is, say someone's been diagnosed with ovarian cancer, they've done a genetic test, they've found out that ovarian cancer is due to a BRCA1 mutation. That's a very common mutation that many people have heard of. Angelina Jolie famously has a mutation in the BRCA gene that leads to a high risk of both breast and ovarian cancer. And importantly, something like the BRCA gene, if you know about that before the onset of cancer, there are steps you can take to prevent cancer or catch it and treat it early. And so this is something we call medically actionable. And in these circumstances, it's really important that family members find out so they can have the opportunity to make the decision to have that test if that's what they choose. In those circumstances, a good clinician would say, this is important that you tell your family members about this. All of your first-degree relatives have a 50% risk of also having inherited this BRCA gene mutation. Not just women, men can also inherit. It's not men or women only. Obviously, men don't have ovaries, but men have prostate, and the BRCA mutation also leads to a higher prostate cancer risk. So any relative, first-degree relative, has that 50% risk. And the doctor should say, this is something that you need to consider telling your relatives. If the patient says, I can tell my one sister, Barbie, but my sister, Marg, actually, I don't really talk to her anymore. It would be awkward to reach out. Can you just tell her? And the doctor says, yes, I can. provide me with her contact details and we will write a letter directly to Marg. We'll tell her about this mutation that's in the family, the potential risks, and let her know that she has an opportunity if she chooses to contact us and come forward for a test.
And why is it important to have this available?
In cases like this, where there are steps that can be taken to reduce risk or sometimes to prevent risk altogether, it's really important that people are given that opportunity while there is prevention available. You can imagine in the scenario I just discussed, if the sister who wasn't really in touch with the patient wasn't told about this, 2 years down the track, she finds she's also got ovarian cancer. It's at advanced stages. She's in stage 4. She does a test. They say, you have a BRCA1 mutation. And then she finds out, oh, my sister knew about this 2 years ago. She knew she had the mutation. She knew I was at 50% risk. If I had this information, I could have taken steps to have my ovaries removed. I could have had screening for breast cancer. But because my sister didn't bother to pass this information on, I've now got terminal cancer and I might die within the next 12 months. This is significant preventive information. And in other contexts, when we think about COVID, we thought about all the contact tracing. How do we make sure that people know that they might have been at risk, especially before we have vaccines? And in other circumstances, when we think about communicable diseases, we really think about who's going to be at risk and how do we make sure that they're notified of that risk so that they can take steps at an early stage. But when it comes to genetics, we get a little bit worried and we get a bit anxious about what that means. And I think we worry significantly about privacy, but we don't worry so much about what information are we failing to give people that might cause them significant medical harm and might even lead to death in cases like the one that I just discussed. And they're not fantasy either, those cases. We hear about cases where people haven't passed on information about genetic risk within families, and then someone ends up with cancer, they have a heart attack, and they find out that if their family had passed on that genetic information, they could have prevented that.
In that situation, we used about if I had ovarian cancer, was diagnosed with it, what would be my next steps? Would I have a genetic test to confirm that I actually do have that gene?
In Australia at the moment, genetic tests are not necessarily available to everybody. This is also something that we are really trying to work on, is enhancing access to genetic testing for the population. And some of the other projects that we work on are around piloting population-level screening for genomics. But at the moment, you have to meet very strict criteria to get a genomic test. Now, if you have ovarian cancer, especially if you're a young person under the age of 40, it is very likely that young ovarian cancer has a genetic cause. We don't always know what it is. We can't always find it, but you're likely to be offered a genetic test. However, if someone is in their 70s and they get ovarian cancer, they won't necessarily have a genetic test offered to them for free under the public healthcare system. If people have a family history, for example, of cancer, they might say, my mum got breast cancer, my auntie got breast cancer, and my grandma got breast cancer. I think that might be in my family. I should get a genetic test. But that doesn't necessarily fulfill the criteria. You have to have a very strong family history. If you have breast cancer and you're under 40 and your mum died of cancer, then they might say that fulfills the criteria. But unfortunately, not enough people are really accessing that genetic testing. We're hoping that will improve. But certainly where someone has a strong family history, when they have a diagnosis of cancer themselves, there are sometimes opportunities to have a genetic test to find out whether that cancer or other disease is caused by genetics. And the other option is that for some people, they could pay out of pocket. So if someone was diagnosed with a breast cancer, they said, look, I'd really like to know if this is genetic. And the doctor says, well, you don't actually meet the criteria. They could say, well, I'd like to pay for that out of pocket because I'd like to know. And those tests used to be thousands and thousands of dollars, but they're coming down in price. And depending on the test that people have and the number of things that they would like to test for, they can now get tests for sort of in the hundreds of dollars. And so it's becoming more affordable for people and for governments to fund this kind of testing.
So in this scenario with the guidelines, the guide, is it for someone who is a patient who has or is getting a genetic test, or is it just for that because that person has something that could be carried genetically, it's in the best interest of her relatives or his or her relatives to contact them, or for the clinician to contact them to say that this has happened?
This really applies when someone's already had their genetic test. So if there's, a strong family history of cancer or multiple heart attacks in the family, we might say that looks like it might be genetic. It looks like it might be running in the family. I wonder if there's a genetic cause for that. At that stage, these provisions don't really apply because we don't actually have genetic test results to share yet. But at the point where someone has had a genetic test, where that genetic test shows that they do have a genetic risk that is relevant for their family members, something like the BRCA mutation or other mutations that lead to high risk of disease, at that point, that's when these provisions really apply, where there's a genetic test result, that genetic information is relevant for family members. The doctor is saying this is something that you should be telling your family about because they could have a genetic test now as well. That's where, at the moment, what's often done is the person is handed a letter and told, you should distribute this to your family members. And sometimes people do hand it to their family members, sometimes they don't. Like I said, sometimes they're out of touch and that it's very awkward or it's difficult to get in touch with them. Sometimes people just forget or they're going through cancer treatment and they can't handle one more administrative task and they think, I'll do that when I'm through this cancer journey, and a year later they've forgotten that they are meant to hand that letter to their family members. So there's lots of reasons why that letter that's usually given to people in that scenario doesn't make it to their family members. And so this is really a mechanism where a clinician, a health practice can step in and do some of that right directly to people. I've also done a lot of other published research in this space. We've done surveys with health professionals and patients and the general public. And we've really found in the people that we've surveyed, there's a strong preference from the public and from patients that they receive that letter from a health professional. We wondered whether people would prefer to receive it from their family member when it's that kind of information. And some people would, but more people said, actually, we would like that letter to come directly from a doctor because we would trust it. We would feel like we could rely on it. There's someone that we can call for more information. And there's that sort of trust in the health system sending that letter rather than it just coming through their family member.
What motivated you to write this paper?
I've been working in this area for a number of years and I have a legal background. So I was a lawyer for about 7 years before I moved into public health about 8 years ago. And that sort of gave me that regulatory lens where I think about, what is the law? How does it interact, especially with genetic information, with privacy? I've done a lot of work on the genetic discrimination issue. And a few years ago, this issue came up because we were looking at ways of increasing what we call cascade testing, and that's the testing of family members. So when someone's at risk and we're passing it on to their family passing that information to their family members. We know that there aren't enough people getting cascade tested, and internationally they kind of peg that figure as below 50%. So less than half of the people who are at risk are having a test. And if they're choosing actively that they don't want the test, that's fine. That's their choice. But we know that many of them aren't actively choosing. They just have no idea about the risk that they're facing and that opportunity. And so I started looking into this a number of years ago and saying, well, what can we do to increase this cascade testing? I say it's the lowest hanging fruit of preventive genomics. It's people we already know about. We know that their family has a genetic high risk. We know that they are often at 50% risk. What are we doing to take that tiny little extra step and make sure that they know about their risk and the potential for testing? And this is one of the things internationally that's talked about is what about clinicians directly writing to people and kind of cutting across some of those challenges with family communication. And I came across a lot of pushback, a lot of concern, a lot of confusion. I did the research that I described earlier with some health professionals and clinicians, patients, a survey of the general public to say, what do you think about this and what are your preferences? I spoke at conferences and I often got feedback from clinicians saying, oh no, we couldn't do that. We're not allowed. That's a breach of privacy. Clinicians are very concerned about privacy, as they should be, but often don't actually know the law. They're not lawyers. They haven't read the Privacy Act. They're really trying to be conservative and cautious, and they're often acting on information that someone else gave them. You can't do that. That's a breach of privacy. And so as I started doing this and I did an analysis of the law and I said, on my assessment, this isn't a breach of the Privacy Act. I think we could be doing this and helping patients better. But there was still a lot of confusion. There are a lot of people saying, well, I don't know, if my hospital would agree about that. And what if it is a breach of privacy? And I can't just believe that Jane Tiller told me that, this is the case. And so eventually last year, I said, well, why don't we try and get an official analysis of this? And so I reached out to the National Health and Medical Research Council, which worked with the Privacy Commissioner on these guidelines a number of years ago, and eventually met with the Privacy Commissioner to say, this is an important issue for clinical genetics. This is an important issue as we move into the mainstreaming of genomics into medical care. It's important that clinicians actually know what the law says and what their discretion is, what their obligations are. And so I worked with them over a number of months last year and early this year, and they said, yes, this is important, and we agree that this isn't a breach of the Privacy Act. And they updated this online guide to make that clear to everybody so that clinicians could look at it and have that confidence to say, well, this is the official interpretation of the privacy regulator of what the Privacy Act says. So for me, my role in public health isn't just to have opinions, but to make sure that there's actual impact and change in policy and practice. And so it's wonderful that the Commissioner has recognized the importance of this clinically and has taken these proactive steps to say, we will make this clear and we'll put this update forward. But I also knew that wouldn't get to clinicians unless there's a pathway to communicate that. And clinicians won't know that there's been an update to the online privacy guide unless it's brought to their attention. And so I've written this paper for the MJA to say, this is where things are at. Here's some information for clinicians. Here's where they can go to get that information, and to break it down in a sort of practical guide so that they can understand what it means for their practice.
So what are the next steps? What happens after this stage of the discovery phase? What are your plans then?
One of the remaining questions is around how this applies in different contexts. So this is the federal Commonwealth privacy regulator, which manages and interprets the Commonwealth Privacy Act. And that applies to people who are working in the private practice, but people who are working in state hospitals or anyone under state jurisdiction also has to comply with the state and territory privacy acts and regulations. And so there are two levels of privacy regulation that apply to people at that federal level and at that state level. Now, the state and territory privacy regulations also have comments about using genetic information. They're all a bit different. In the previous analysis that I published, I looked at the Commonwealth Act and also all of the state and territory acts. And again, my assessment is that they all have consistent wording and applications and discretion that would be applied in the same way, that this is something that can be done without breaching those privacy regulations. But similarly to the Commonwealth situation, we don't yet have something in writing confirmed from each state and territory to say, yes, we agree that this is the interpretation of the State and Territory Act. And so the next step for us is to go to them, and there has been some discussion and some consultation with the health departments to date. But we would like to see a more consolidated approach to that, where the states and territories can also all come forward and consider their own acts and how this applies. And ideally, the scenario would be in the future that we have a consistent message that we know that this same interpretation applies to all of the state and territory privacy acts in the same way that it applies to this Commonwealth Act.
Sort of touched on this before, but what about the right not to know? How does that work?
People often raise this issue of the right not to know. What if people don't want to know about their genetic information? And it is an important thing to consider. It's not really a legal right per se, but it is an ethical concept that we think about. We don't force information on people. We don't force medical interventions on people. And the important thing here to think about is the concept of autonomy. And as I mentioned briefly before, the question often isn't, have they exercised autonomy? Because they don't know about this information. They don't know that there is a risk available to them. And there's a big difference between the right not to know your genetic result and a right not to be told that you might be at risk. People can't make an informed decision if they don't even know that they might be at risk. And it's important as well to remember that in the normal scenario, which already happens day to day, we hand the patient a letter and they hand it to their family members. That's kind of how it's supposed to work, but we know it doesn't. And so there's no real difference between someone handing a letter to their family members and someone asking their doctor to write to them. Either way, that person finds out about possible genetic risk. They're not forced to follow up on that information. They're not forced to have a test, and it doesn't tell them what their result is. It just tells them about the potential for risk and the availability of testing. If they want to throw that letter in the bin, if they want to never think about it again, if they don't want to have a genetic test, that's autonomy. That's them choosing that they don't want it. But if they don't get the letter and they never know and they can't make that informed decision whether to have a test or not, that's unfortunate, and that's really taking away their autonomy.
Is there anything you'd like to add?
This is something that at the moment is mainly relevant for genetics clinicians working in genetics contexts, but we know that genetic information is relevant across all types of medicine, and we're in an era where this kind of information is rapidly progressing into every area. People who are oncologists are already dealing a lot with genetic information. Cardiologists, people in the heart disease space are already dealing with genetic information. But more and more and more, genetics, genetic information, cascade testing, communication with families is something that every clinician in every area of medicine is going to have to think about and is going to have to work on. And so even people who aren't genetics specialists and who are in all different types of areas of medicine, I think it's very important for them to be across this kind of update, to understand what their obligations and discretions are, so that when they are faced with a genetic test result and they are faced with trying to think about, is this important for family members, and how can I use this information, and what can I do to make sure this gets to family members, that they're clear on where the law is. And that's why a journal like MJA, which has a readership across such a broad medical specialty area, is a really important place for this kind of piece.
Thank you to my special guest, Dr. Jane Tiller. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thanks so much for listening.